Welcome to Module 5. In this module, we will cover advanced techniques in trauma quality improvement programs. As with the previous modules, the information in this presentation is largely based on the guidelines for trauma quality improvement programs produced by the World Health Organization. On your screen, you will see the web address where this document may be found. The goal of all QI methods is to identify and correct problems. M&M conferences and preventative death panels are mostly retrospective in nature and qualitative and sometimes subjective judgments based on chart review, discussion, and expert opinion. The methods in this section represent more objective and analytic approaches that utilize prospective data collection. They have in common monitoring for problems and specific events. These events may or may not contribute to an unwanted outcome. Often these techniques require more extensive resources, such as staff time for gathering data and computerized information systems. Audit filters can identify near misses in patient care that do not result in poor outcome but might indicate a patient care process that can be improved. Particular cases identified by the audit filters are then reviewed on a systematic basis to see if indeed there was a problem with the quality of care delivered. One may screen all audit filters routinely or screen only for specific filters that have been determined to be of interest for an institution. Audit filters can be broken down into areas of care. For example, pre-hospital care issues may include appropriate personnel, stabilization, and the timeliness of transport. The emergency department issues may include proper utilization of resuscitation principles, protection of the airway, intravenous access and resuscitation, and the rapid and complete identification of injuries. Another important phase captured by audit filters is timing to the operating room for various injuries, such as penetrating abdominal trauma, intracranial mass lesion drainage, and washout and repair of open fractures. Other issues include the timely presence of appropriate personnel, such as nursing, medical, and subspecialty services, as applicable per institution. The various audit filters capture a number of additional concerns, such as unplanned operation, delays in care, and documentation issues. Audit filters can be approached as either Sentinel events or as rate-based filters. Sentinel events are filters for which even one case prompts review, such as death with low injury severity score. Rate-based filters are those in which a certain low percentage of non-compliance is expected, such as delays in reaching the operating room in patients with open fractures, a certain proportion of whom would be expected to have such delays for valid reasons, such as when the care of life-threatening injuries takes precedence. Review is prompted if these filters exceed certain threshold percentages. Potential drawbacks of audit filters are the cost and lack of extensive published examples documenting the utility of specific filters. The staff time required and the cost of evaluating audit filters for every trauma patient may prove prohibitive to routine screening for many of the audit filters. As a result, in one particular high-income country, the United States, the American College of Surgeons has recently changed from giving a list of specific filters for which trauma QI programs should audit to merely recommending the QI programs should track some filters depending on local priorities. Audit filters may have great potential in low and middle income countries where there are fewer pre-existing trauma QI activities in general. For example, the Trauma QI program in Khon Kaen, Thailand tracked 32 audit filters. These were felt to be an important component of the program's success in reducing preventable deaths. Similar experience early on in Pakistan has been reported. Assessing for the defined audit filters during preventable death panel reviews has been shown to identify different types of issues according to the system examined. While assessing preventable deaths in a mature trauma system, the most likely contributors to poor outcomes were delays in treatment and judgment errors. In contrast, in low and middle income countries with less mature systems, different factors were identified as responsible for preventative deaths. These include inadequate pre-hospital care, inappropriate transfer, limited hospital resources, and an absence of integrated trauma care. Depending on the resources of a hospital or system, audit filters should be used to track every patient or as an additional point of analysis in preventative death panel reviews. Before we move to the next section, I would like you to take a moment to think of what kind of complications might occur within your institution or system. Complications are unexpected, unplanned, and unwanted outcomes. They are either secondary to natural disease processes or a result of an adverse event. An adverse event is defined as an injury that is caused by medical management rather than an underlying disease and that prolongs hospitalization, produces a disability at discharge, or both. While all adverse events are complications, not all complications are secondary to adverse events. A long list of potential complications may be systematically screened for, identified, recorded, and tracked as indicators of the quality of care. I would like you to take a few seconds to identify some complications that have arisen in your local setting and identify what they resulted from. Next, I would like you to take a few seconds to think about how complications can be tracked. The process of tracking complications looks for rates of complications that are higher than would normally be expected. If a high rate of a particular complication is identified, a directed investigation should be undertaken to sort out the underlying reasons for the detected increase. Once reasons for the unusual increase in complication rates are identified, corrective measures and strategies should be implemented to reduce the complication rates to an acceptable level. On your screen is an extensive list of potential complications that can be tracked. An error is defined as failure of a planned action to be completed as intended or use of a wrong plan to achieve an aim. An error can be thought of as a failure to follow accepted practice at an individual or system level. An error can result in poor outcome, but an error may also occur without causing any negative impact on an outcome. In contrast to a complication or adverse event, which are by definition end results, an error is a contributing factor. An error that does not result in a bad outcome can also be thought of as a near miss. While an adverse event can be due to an error, most adverse events are not errors. An adverse event attributable to an error is a preventable adverse event. Error can be categorized into subtypes. Several taxonomies of types of errors are in use. For instance, the experience in South Africa of adapting the error theory used in aeronautical safety to trauma QI work. Another useful taxonomy is that developed by the Joint Commission on Accreditation of Healthcare Organizations in the United States. This taxonomy classifies errors based on impact, type, domain, and cause. Impact implies the harm done by the error ranging from none to permanent impairment or death. Type implies the patient care process that was faulty, such as errors in diagnosis, treatment, prevention, communication, and equipment failures. Domain implies the setting in which the error occurred, such as pre-hospital, initial assessment, secondary survey, resuscitation errors, operative errors, and critical care errors. Floor ward and rehabilitation errors also occur but are less frequent. Cause implies the factors leading to an error. These are usually further grouped into system errors or human errors. System errors include errors in design, organization, and maintenance of both the physical system and the organizational system. The physical system includes facilities, equipment, and infrastructure, while the organizational system includes management, organizational culture, protocols, and processes, as well as training. Human errors involve direct contact with the patient and are often the proximate cause of the error. A more detailed classification of human errors looks at the process of decision-making and implementation of a management plan in the care of the injured patient. This classifies potential errors as diagnostic or input errors, intentional errors, or execution errors. Listed here are the 3 types of errors that I just recently mentioned. These include diagnostic, intention, and execution. An example of a diagnostic error is failure to diagnose intra-abdominal hemorrhage and subsequent delay in operative intervention. An example of an intention error is awareness of a threatened airway in a hypoxic head-injured patient, but failure to take steps to clear and establish a secure airway. An example of an execution error is making the decision to secure the airway with an endotracheal intubation, but misplacing the tube in the esophagus rather than the trachea. A particularly egregious adverse event is termed a sentinel event. A sentinel event is defined as an unexpected occurrence resulting in death or serious physical or psychological injury or risk thereof. While all sentinel events are adverse events, not all adverse are sentinel events. A sentinel event is a severe adverse event with a particularly bad outcome that prompts an immediate and thorough investigation of the circumstances contributing to the poor outcome. When such a bad outcome occurs, a separate QI investigation process called a root cause analysis, or RCA, might be undertaken. RCA is a process for identifying the etiology of an anticipated poor outcome. The RCA type of QI investigation consists of forming a separate team to analyze the reasons for the poor outcome in a particular case. The RCA team should be interdisciplinary and focused on identifying and understanding unanticipated issues that resulted in the poor outcome. The RCA investigation should be short-lived with quick deadlines. Again, this RCA is a one-time process that looks at the event behind a particular case rather than an ongoing data collection and data monitoring of all cases. The goals for an RCA team are listed here. These goals include analyzing thoroughly an unusual event, delineating what systems issues allowed such an event to happen, and design measures to prevent similar poor outcomes. The steps that an RCA team uses to address a sentinel event can be useful guidelines in approaching any adverse event that a QI program might encounter and wish to investigate. A number of different scoring systems exist to help compare injuries between patients in an objective manner. Some of these scoring systems are based on anatomical nature of injury sustained, and some are based on the physiological status of a patient. The best known and widely used scoring systems are the Abbreviated Injury Severity, or AIS, the Injury Severity Score, or ISS, the Glasgow Coma Scale, or GCS, the Revised Trauma Score, RTS, and the Trauma and Injury and Severity Score, or TRISS, or TRIS, and a Severity Characterization of Trauma, or ASCOT. Through such statistical processes, hospitals evaluate the percentage of deaths occurring in patients with low ISS or a low probability of death based on either one score or on a combination of these scores. A trauma QI program can set up a system to evaluate unexpected deaths identified by the various scoring systems. For example, the trauma QI program can mandate examination of all deaths in patients with minor injuries as identified by an ISS of less than 9 or probability of survival or a PS greater than 90% as calculated by TRIS to make sure that an appropriate level of care was achieved. Use of statistical methods also allows a hospital to compare itself against predetermined national and international norms. Hospitals with risk-adjusted death rates higher than expected may warrant evaluation of an individual unexpected deaths along with evaluation of the systems of care to identify elements that may contribute to such a high risk-adjusted mortality. Any of the above-noted risk adjustment methods add increased objectivity to the QI process. However, it must be noted that they also increase resource requirements, especially in terms of staff time for injury severity coding. Use of statistical methods also allows a hospital to compare itself against predetermined national or international norms. In summary, the goal of all QI methods is to identify and correct problems. M&M conferences and preventative death panels are mostly retrospective in nature with qualitative and sometimes subjective judgments based on chart review, discussion, and expert opinion. QI advanced techniques include audit filters, complications, errors, adverse events, and Sentinel events. These techniques represent more objective and analytic approaches that utilize prospective data collection. Advanced techniques of trauma QI all monitor for problems and specific events. These events may or may not contribute to an unwanted outcome. Often these techniques require more extensive resources, such as staff time for data gathering and computerized information systems. Thank you for completing Module 5 on Advanced Techniques for Trauma QI.